very important. So in this surgical visual phase, the first image based question that we have in front of you is identify the stone. Now what are the 4-5 important things that we need to understand when we are observing this stone? What is the color of the stone? So when we talk about the color of the stone, this is brown, or you can say reddish brown. So when we talk about reddish brown, we are tempted to think that could it be calcium oxalate stone. But the very next thing that we need to understand is what is the texture of this stone. This is again very important. Now when we talk about the texture, if you see on the outer sides, we have something which is smooth. So this is smooth on the outer side. So smooth on the outer side. The very next important thing that we all need to understand, it is hollow in the center. So something which is hollow in the center, smooth on the outer side, it is just like a eclairs where you have molten chocolate inside and then smooth on the outer side. So what are you dealing with? You are dealing with a matrix stone. Why it is not a calcium stone, calcium oxalate stone, why it is a matrix stone? Let us understand the difference. The calcium oxalate stone is actually a white color stone with a laminated, you can say, covering of the hemosiderin, which gives it a reddish black or reddish, you can say, brown appearance, but it is not smooth. The second thing, it is not hollow, it is not having pus. But here if you see, it is hollow with pus inside, it is smooth on the outer side, and it is looking a bit fluffy. So what are the 5 important things that we all need to understand about the matrix stones? So when we talk about matrix stones, they are protein rich stone. So protein rich. The second thing that you have to understand is they are 100% organic stone. Now what do you mean by organic stone? They are grown without fertilizer. No, students. The organic stone means that it is not having inorganic components. So calcium, magnesium, ये सब कुछ भी नहीं होता है. So what happens? The inhibitor proteins. What are the inhibitor proteins? We have the TAM horsefall, we have nephrocalcin, we have osteopontin. ये जितनी भी inhibitor protein है, because of the recurrent urinary tract infections, UTIs, there is cohesive clumping of the proteins. And when there is cohesive clumping of the inhibitor proteins, thus they form a stone which is soft and spongy. And remember, inside it you are having the pus which is filled. So they are soft, spongy. Remember one very interesting thing, that they are so spongy that they absorb the shock wave without getting broken, and that is why they are ESWL resistant stone. The next very interesting fact that we need to understand about these matrix stone is that the treatment of choice for these matrix stone is RIRS. What is RIRS? Remember, when you put them in the kidney, they are so soft and spongy that you keep on hitting them, they will not break. So ESWL का कोई point बनता नहीं, and that is why you go in with a rhinoscope and you just pick them and take them out. Or if RIRS fails, then in that case PCNL is the call. But remember, matrix stones are what resistant? ESWL resistant. So जब भी कभी ये image आएगी, you should be knowing about these stones. One point on this, struvite. I hope you know that struvite stones are also associated with infection. In fact, the word infection stone is reserved for the struvite, but they are not in this. So they are white in texture. The next thing is that they are not spongy. They have a totally different orientation. So hollow spongy stone with pus filled inside. There is only one stone, dear students, that is matrix stone. Cystine stone, you need to understand that it is the hardest. What is so special? Because it is sulfur rich stone. Since it is sulfur rich, it is loaded with that bluish color. So bluish green appearance is what is very commonly seen. The next image based question that we have, you are getting an image where you have pneumothorax. Now first thing is you need to identify कि कौन सा pneumothorax है, and then the second is what is the concept. So first thing I want from the audience is, tell me what type of pneumothorax is this. So you can understand pneumothorax is when air is inside. So you can see the air is there. You have, if you see, there is one injury. So this is the first injury, and injury to what pleura? the injury to visceral pleura is there. The next thing is, this is the second injury, and when we talk about the second injury, this is the injury to parietal pleura. So visceral pleura is injured, parietal pleura is injured, and this is connected with the atmospheric, you can say this rent is communicating with the external surface. So the first very important thing is, what kind of pneumothorax is this? Yes, you are getting it right. This is open pneumothorax. So when we have open pneumothorax, what is the concept? Both the pleuras are injured and the lung cavity is communicating with the external atmosphere. Now the next is, what amongst them is false? All except are true. So what is false? It is a double pleural injury, absolutely true. The sucking wound effect. Why is the sucking wound effect is seen? You can see the air outside is having the pressure which is more. So P atmosphere is far more than P, you can say, pleural cavity. So I'll take you to the next page and there I will discuss about this. So whenever we talk about this question, you need to understand a very simple thing, that the P atmosphere is far more than P pleural cavity, and when this happens, the air will be sucked in from the wound, and that is why therefore this is known as sucking chest wound, and this is really very important. Why? Because this is the basis of all the problem. Air बाहर से अंदर जाने लगी, and this movement of air will continue जब तक P atmosphere equals to P lung, or you can say P pleural cavity. The moment the P atmosphere is equal to P pleural cavity, you know what will stop? Respiration will stop, and that is why that this is considered as an immediate life-threatening condition. So what is this phenomena known as? This phenomena is known as equilibration of the pressures on both the sides. So because of the equilibration of the pressure, this happens. Now बच्चे, patient has been brought to ER with such a scenario. अब अगली चीज़ क्या करोगे? Many people do a mistake that they don't understand the kinetics properly, and वो कहते हैं कि the first thing is, sir, I understand, since the air is entering this cavity from outside, I will put a dressing and I will occlude it so that I disconnect the external surface. बिल्कुल सही है. You disconnect it. So one, virtually you have put a stoppage to the inward movement of the air. But what about this? There are double pleural injuries, na? So what about the inner visceral pleura which has been injured, which leads to conversion of? So अगर आपने गलती से भी occlusive dressing, if you put an occlusive dressing on all the, you can say with occlusion on all the sides, this will convert open pneumothorax into what, students? Into a tension pneumothorax. This is the second most important point, and that is why this is a double trap. So why this is a double trap? Because two visceras are injured, two, you can say, pleuras are injured. So आप क्या करते हो? Sir, if we don't put, you can say, suppose this is the injury, if we don't put a dressing, then also it's a problem. So what you put? You put a dressing which is wider than the defect size. So when you put a dressing which is wider than the defect size with taping on three sides, so what will happen? The air will not enter, but this side is open. So the moment you inspire, the pressure inside is elevated and the air exits out. So what is the temporary? What is the temporary? Or you can say, what is the emergency management? Answer is dressing with taping on, dressing with taping on how many sides? With taping on three sides. This is what is very, very, very important. Now this will give you time. And what is the definite management? So this is again very important. So definite management is, sir, I will open the thorax, so thoracotomy with repair of the injuries. So let us get back to that question and see what the question is asking from us. So all except are true for the following condition. It's a double pleural injury, true. Dressing with taping on three sides is ideal management. We'll come back to this. Sucking wound effect is created, true. Equilibration of pressure on both the sides. बच्चे, all four options seem to be right. But what is the problem? This is the ideal management? No, this is the emergency management. So this is emergency management, and the first step to restart the process of ventilation. Once this has been done, then again we will be going for the surgery. So option B is the answer of exclusion in this. Bache fatafat I will show you the image. What is that occlusive dressing with taping on 3 sides. I'll show you that. Okay, so just give me. Okay, so just see the very same question. The patient presents to ER with thoracic trauma with the following dressing done. So I have already taught this question. I have seen that. So this is done for. So what is it done for? Answer is this is a dressing with taping on what sides? 3 sides. So can you see dressing with the taping on 3 sides and air can vent out from this. So diagnosis is open pneumothorax. I've already told you what is the approach, what is the management. So with one stroke we have done 2 questions. Let us come back and let us understand more important question. चलो फटाफट ये वाला question भी कर लेते हैं. A patient presents to ER or patient presents to you with severe pain in the abdomen and a palpable mass. So patient presented with a severe pain and palpable mass, and a diagnostic lap was done. Diagnostic laparoscopy was done, and this is what is the image. Now, you know, usually in surgery we are not getting a lot of questions from the inflammatory bowel disease, but nowadays this is becoming a trend. Bache, what are you seeing? Can you see the bowel? Sir, I can see 2-3 things. I can see a bowel. Yes, I can see. Then I can see the mesentery. This is the mesentery. And it is like the wax is molten wax is falling out. So, bache, what do we call this phenomena? This is creeping fat. This is the creeping fat over the mesentery. So, whenever there is creeping fat over the mesentery, what is it diagnostic of? So it is diagnostic of what, students? Crohn's. Very important. So maybe this is Crohn's colitis or maybe Crohn's enteritis. So this is really very important. So how do you diagnose it? Yes, colonoscopy is the investigation of choice. Ideally, colonoscopy is the investigation of choice. On colonoscopy, what are the important macroscopic findings that will help you diagnose? Bache, Crohn's, try to understand, it's a complete, C for Crohn's, it is complete transmural, you can say, infection. So when we talk about Crohn's, what are the things that we have? So remember, the moment you deal with a patient of Crohn's, the first is, it is complete full thickness. So full thickness inflammation. So full thickness, the word that we use is transmural inflammation. Point number 1, that is what you see. The second thing that you get to see ulcers, you get to see fissures. So ulcers, fissures, and remember, non-caseating granulomas. So non-caseating granulomas, this is what is again a finding. When you talk about the other important things that we get to see, there may be strictures, there may be fistulization with the nearby structures. So strictures, fistulization is there. One very interesting point is that between the inflamed areas, you have a normal, you can say, looking mucosa. So if you see, the mucosa in between them is normal, but it is edematous. So the normal mucosa with the inflamed mucosa, this gives a typical cobblestone appearance. So cobblestone pavement appearance. So cobblestone appearance, what do you mean by this? So these are the ulcers, transmural ulcers, and this is the normal edematous mucosa. So this is what is the classical Crohn's colitis or Crohn's enteritis. I'll also discuss with you the, you can say, differentiating factors, how we differentiate Crohn's from the, you can say, from the ulcerative colitis. But very important thing that we need to understand in this is, when we are talking about the Crohn's, what is the classical presentation? Because Crohn's, unlike, you can say, unlike ulcerative colitis, will not present to you with severe diarrhea. So yes, pain is the most important. So pain is the most important, and then you will have abdominal mass. And many a times a young female or a young patient presenting to you with pain and mass, you always think of, you can say, think of maybe a tumor, something like that. So pain with abdominal mass, this is the classical thing, and along with that you may be having malabsorption, because what is the reason for this malabsorption, ये भी बहुत important है. So malabsorption, there may be mild diarrhea. Diarrhea is not severe, it is mild diarrhea. There may be, the patients may be anemic, so anemia might be there. So what is the reason for malabsorption? Now try to understand, this is the transverse colon. Imagine this is the transverse colon, and then you have a small intestine adhered. Initially there is inflammation, there is adherence, and now because of this there is a fistulization. So there is a fistulization in between them, and now what is going to happen? The bacteria from this, the bacteria from transverse colon will enter into this. Now this is a classical myth. Lot of you believe कि because why diarrhea happens or why malabsorption happens, because the small intestinal contents directly bypass into the transverse colon or colon. That is why diarrhea happens. No, absolutely wrong. Go to main go to Shackleford, अच्छे से समझाया गया. The diarrhea, the malabsorption is not because of this, rather it is because of the colonic bacteria which go into the small intestine, resulting in blind loop syndrome like condition, or maybe the bacterial overgrowth induced diarrhea. So malabsorption happens because of the bacterial overgrowth, not because of the bypass. ये कुछ चीज़ों को ध्यान से रखना. Then we have the Montreal's classification or Vinya's classification, where we have the classical thing like we have A for age. So when we talk about the Montreal classification, so first of all, Montreal classification or Vienna classification, this is for. So A is for age. So based upon the age, then L is for location, and B is for behavior. So this is how we define the Crohn's colitis. बच्चे, we have true love classification for the ulcerative colitis, where we have mild, moderate, severe and critical or fulminant basically, but Montreal, so don't get confused. So A, A1 is age up to less than equal to 16 years, A2 is more than equal to 17 up to 40, and A3 is more than 40. This is what is simple, very, very, very simple. When you talk about behavior, we have B1, which is non-stricturing, non-penetrating. So non-stricturing, non-penetrating, this is what is B1. Then we have B2. This is the what pattern? When it is a stricturing, only the stricturing pattern. Then we have B3, it is the perforating or penetrating variety. Yes or no? And then if in any case the perianal region is involved, so if in any case perianal involvement is there, we will always add the P word. Based upon that, yes, we have to, it may be B3P, B2P, and then when you have L1, it is the ileal. Then when we have L2, it is the colonic. Then we have L3, this is the ileocolic. So bachche, we have seen how this Montreal is, and again P is for the perineal. So Montreal classification is for this. Bachche, what are the classical differentiating factors between ulcerative colitis and the Crohn's? Ulcerative colitis is exclusively confined to colon and rectum, and the perineum is spared. Whereas Crohn's can be seen universally anywhere in the body. This is very important. The risk of malignancy is higher in ulcerative colitis. Ulcerative colitis, remember, U for upper, so it is confined to the mucosa only. Intense mucosal inflammation resulting in fulminant diarrhea, moderate to fulminant diarrhea, multiple episodes of diarrhea. Basically, we define it into mild, moderate, you can say severe, depending upon the episodes of diarrhea. Up to 4 diarrhea, no other presentation is mild. Up to 6 episodes of diarrhea, mild anemia, it is, you can say, moderate. More than 6 episodes, up to 10 episodes, and along with that significant anemia, elevated ESR, it is severe. And then you have fulminant or critical disease, where yes, you have the severe level of diarrheas, more than 10 episodes, with, you can say, very severe fulminant level of colitis. So ये सारी चीज़ें आती हैं. This is how you grade the ulcerative colitis. Perineum I have already told you. No stricture, no perforation, no fistulization is seen in ulcerative colitis. Here it is seen. So this is how we approach. Now when we talk about the management, the first line management when we talk about them is medical management. So medical management is preferred. If it fails, then only you go for surgery, and surgery is basically for the complications, not as a standard of management. We have steroids, we have monoclonal antibodies, we have lot of category of drugs that we have. So immunosuppression or immune response modification. Remember, there are two categories of drug. The scope of this session is not, we cannot discuss everything, but remember, something is for remission and something is for maintenance. So remission, once the remission is achieved, then we go for the maintenance therapy. So let us go and go to the next question, and let us divide that also. But say if you see, this is my very old, you can say, IBQ series, and every year I keep on adding. ये तो बहुत पुरानी photo है, last year NEET PG ने पूछी, but it's a very common question. A patient presents to you with clear discharge from the ear. This is what is very important. So clear discharge from the ear with perimastoidal hematoma. Identify the cause of, you can say, identify the cause of the image shown and discuss the following: diagnosis, approach and management. What are you seeing here? This is very simple to understand. Sir, RTA का patient है, and along with that there is otorrhea. So there is RTA with otorrhea, and along with this you have the perimastoidal hematoma. So when we talk about perimastoidal hematoma, the answer becomes very straightforward. And what is the answer? We are dealing with the Battle's sign. So battle sign, what is the reason for this? Basically this is associated with the skull, or you can say base of skull fracture. This is really very important. So base of skull fracture, and this is particularly the middle 1/3 of the skull base fracture, which is going to result in this. Next is how do you diagnose the things? Clinically we have seen, you need to confirm it with the biochemical test. So let us understand each and everything. So whenever we revise about the base of the skull fracture, so base of skull fracture, you know that it could be involving the three parts of the skull. Let me draw this. So it could be anterior 1/3, it could be middle 1/3, it could be posterior 1/3. Quickly let us revise it quickly. So let us create this skull, and you know one very interesting finding, that the base of the skull is having a packing. And what is this packing known as? This packing is known as gallia aponeurotica, but this gallia is not present in the anterior 1/3 part. So whenever there is anterior 1/3 hematoma, you don't need to, you can say, always get to see CSF rhinorrhea, because anterior 1/3 the blood might trickle down and it might collect around the, you can say, orbit. So you can see it might collect around the orbit, resulting in something which is known as raccoon eye. Vice versa is not possible, that if the patient is not having any hemorrhage, I'll tell about that, just give me a minute. So anterior 1/3, middle 1/3 and posterior 1/3. अब देखो इसमें बड़ी sensitive सी चीज़ क्या होती है बच्चे, injury in the anterior 1/3 will also damage the cribriform plate, and whenever there is injury to cribriform plate, what shall trickle down? The CSF shall trickle down. बच्चे, this is a traumatic event, so blood will be there and blood will collect around the eye, resulting in raccoon eye. So I was telling that there could be possibility कि anterior 1/3 में blood है and that blood trickles down without CSF rhinorrhea. So ये possibility है that patient is not having CSF rhinorrhea but raccoon eye is there, but vice versa is not possible, that CSF rhinorrhea is there, raccoon eye is not there, because CSF rhinorrhea is occurring because of the trauma and there will be collection. Where is it useful? I will tell, just give me a minute. Next is in the middle 1/3 you will have CSF otorrhea, and along with that you will also have the perimastoidal bleeding. So there will be Battle's sign. Now try to understand, the base of the skull is known for the nerves. So what are the nerves that will be seen here? Nerve injuries. So cranial nerve injury 1 and 2. So when we talk about cranial nerve injury 1 and 2, here 5, 6 and 7. Here basically, it is the 6 and 7, and here it is 9, 10, 11 and 12, and therefore you can understand, you can get to see the Collet-Sicard, syndrome, this is one, and Gill-Vernet syndrome. So Gill-Vernet syndrome and Collet-Sicard, basically Gill-Vernet is because of the injury to 9, 10 and 11, and Collet-Sicard is 9, 10, 11, 12. Anyways, leave it. बच्चे कई बार क्या होता है, you have a eustachian tube, and via this eustachian tube the CSF might be sniffed going into the oropharynx, and it may be sniffed and it might be coming out. So yes, if the CSF comes out when you have a middle 1/3 injury via, you can say via nose, that will be known as paradoxical CSF rhinorrhea. Now how to differentiate paradoxical CSF rhinorrhea with CSF rhinorrhea? Question number 1. CSF rhinorrhea anterior 1/3 है, but paradoxical CSF rhinorrhea middle 1/3 है. जब भी कभी whenever you have CSF otorrhea with CSF rhinorrhea but no raccoon, that means it is middle 1/3. Whenever you have CSF rhinorrhea with a raccoon eye, it is always anterior 1/3. Otherwise, it is quite impossible to differentiate it. Whenever we talk about how to confirm it, we have the bedside handkerchief test, and whenever you go for the, you can say, assessment. So bedside assessment, what is that? Since it is blood and CSF, you will have the inner dark ring and outer, you can say, outer light ring. So outer ring is because of the CSF, inner dark ring is because of the blood, and this test is known as halo test. And then when you go for lab or biochemical, so beta 2 transferrin, this is the investigation of choice, or you can say this is beta 2 transferrin assay basically, or confirmatory. Now along with that, one more thing that we need to understand is, बच्चे ये CSF rhinorrhea traumatic है कि atraumatic है? So this is confirmation for CSF. So this is how beta 2 transferrin assay you have done. But how do you confirm whether it is traumatic? Then we have apolipoprotein E2. So apolipoprotein E2 is confirmatory of neurotrauma. So if you have a slightest of the doubt कि leak old है, is it traumatic? So always note beta 2 transferrin, along with that apolipoprotein E2 will be elevated. So very important, conservative manage करोगे. If you think that it is not responding, then only you will go for CSF lumbar tapping to decrease the pressure. Still if it fails, then you go for transsphenoidal fixation. This is very, very, very simple. Next thing is, let us understand this question. A 26-year-old girl presents to you with the following skin lesions. So you can see there are multiple patchy lesions over the intertracheous area, basically the groin areas or maybe the axillary folds. यहाँ पर बड़ा common होता है, especially in the groin areas. Female, she also has a history of tricyclic antidepressants for last 3 years. So tricyclic antidepressant कोई मौज में तो खाएगा नहीं. Patient may be having depression. She developed DVT. So now you can see she is having dermatitis. So dermatitis, point number 1. Along with that, she is having DVT. Along with that, she is also depression. So depression, dermatitis and DVT. So these 3 things are present. Now identify the pathology shown in this. A young female with this kind of lesion. बच्चे always think that could it be because of a pancreatic tumor? बच्चे इस question में थोड़ी सी information is less. Now what is the nature of these, you can say, skin lesions? These skin lesions are seen to disappear also, or it is seen to actually creep out of their initial locations where they were found. So बच्चे इसको कहते हैं NEM, necrotizing erythema migrans. So when we talk about necrotizing erythema migrans, and along with that you have dermatitis is clubbed with DVT, depression, and nothing is mentioned about the blood glucose profile. So along with that, if the patient is having diabetes, this is diagnostic of glucagonoma. So glucagonoma is a pancreatic tumor. And what kind of pancreatic tumor? It's a neuroendocrine tumor of the pancreas where you have increased glucagon. And why there is increased glucagon? Because these are the tumor of the alpha cells. So these tumors are known to cause this necrotizing migratory erythematous lesions. Along with that, so remember the 4 Ds: dermatitis, DVT, and depression or dementia also. So this is diagnostic of glucagonoma. It's a malignant tumor. So the initial management is, yes, you can go for streptozotocin, which can destroy this endocrine component of the pancreas, but definite management is resection. And do you know the prognosis for these patients is poor. So ये classical image याद रखना, बड़ी common सी image है. Let us move forward and let us understand this next image. इसमें थोड़ी सी hint और मैं दे देता हूँ. A patient, a known patient of BPH, benign prostatic hyperplasia, with bothersome LUTS. अब थोड़ा सा easy हो जाएगा, अदरवाइज एकदम से ये इंफ्रारेड जैसे इमेज देख के it is very difficult to identify. A patient with BPH, benign prostatic hyperplasia, everyone knows, with bothersome LUTS. What is LUTS? Lower urinary tract symptoms. You have two category of lower urinary tract symptoms. एक होता है voiding related और एक होता है storage related. So whenever a patient is having BPH, the problem is very simple. The problem is, sir, because the outer capsule is not allowing the mass to grow, the adenoma has actually compressed the urethra, because of which the flow has been obstructed. The second important thing is, this adenoma is a stromoglandular adenoma. So there is increase in alpha, you can say, or you can say alpha receptors, and thus there is a dynamic as well as a function, you can say dynamic resistance. Because of the increased alpha, the urethra has been further collapsed. इसीलिए voiding या LUTS होता है, voiding symptoms of LUTS, that is lower urinary tract symptoms. अब when patient is not responding to the conventional management, since it is a benign condition, we have a lot of, you can say, interventions. And what is the classical that you all know? You all know about TURP, that is transurethral resection of prostate. Then you have TUVP. What is TUVP? Transurethral vaporization of the prostate. What is the difference? In this you use a resectoscope. A resectoscope is used, that is having a wire, and here you are having the electrode. So electrodes are used. बच्चे उसके बाद क्या होता है? There are thermal ablation techniques. So this is what is known as TUMT. What is TUMT? Transurethral microwave ablation therapy. Now what do you mean by transurethral microwave ablation therapy? Are we going to take out the prostate, put it in the microwave, set a timer to 5 seconds or 30 seconds, and then we can see, okay, it's crunchy or no? But we use that same klystron tube to generate the heat. And if you see the microwave, but this is the heat graph, this is the infrared image, because you know in infrared it is the heat which is having different colors. So you can see the red, yes or no? So this is the red, then we have yellow, then we have the green. अभी माइक्रोवेव में एक समोसा रखो और यू कीप अ बर्गर, यू वांट टू हीट अ पैटी, जो उसका इनर मोस्ट पार्ट होता है, दैट इज हैविंग द मैक्सिमम, यू कैन से इज हॉट. कई बार ऐसा होता है, द पैटी इज यू कैन से लुकिंग कोल्ड फ्रॉम आउटसाइड, बट व्हेन यू ओपन इट द इनर पोर्शन इज हॉट. दैट सेम थिंग इज हैपनिंग हियर. जस्ट बाय सीइंग द इमेज यू कैन आइडेंटिफाई कि हो क्या रहा है. सो दिस इज अ थर्मल एब्लेशन. This is a thermal ablation of the prostate. And when you talk about thermal ablation of the prostate, this is TUMT. What is TUMT? Transurethral microwave therapy. बच्चे प्रोस्टेट कहाँ है? दिस इज द प्रोस्टेट दैट यू हैव, दिस इज द ब्लैडर, दिस इज द कैथेटर बाय विच यू हैव डन. रिमेंबर, ablation is done. What is the indication? For the glands, this is done for the glands more than 80 grams, more than 80 grams gland अगर है तो बच्चे TUMT is not done for the glands which are less than 40. Basically 25 का कट ऑफ बुक्स बोलते हैं. If you go to Campbell's they say 25 में नहीं हो पाता है. For them we have the Tagris antenna or TU, you can say TU, transurethral needle ablation, TUNA, that is a different thing. But ये laser ablation नहीं है, this is TUMT, this is what is. So 42 degree Celsius से लेके 45 degree Celsius is the standard temperature that we have in the core. When you talk about the core, the temperature may go as high as 80 degree to 100 degree Celsius. So basically we have a different range of temperature, and this is what is the classical concept of the TUMT. Without wasting time, बच्चे, let me quickly discuss with you the classical concept of what do you mean by LUTS. Lower urinary tract symptoms में सबसे important चीज़ होती है, we have two category of symptoms. We have symptoms associated with the voiding, and the second is we have symptoms associated with the storage. So storage symptoms में क्या होगा? If you are storing something and you are not voiding it out, so you will have the frequency, high frequency. Not only frequency, you will have urgency. During night it will be more in movements because of the lower sphincter resistance, and a time will come when there will be urge incontinence. The body will start ignoring the things, so there will be urge incontinence, and this will lead to overflow, and thus it will lead to overflow incontinence. So ये सारी चीज़ें आती हैं storage पे. Voiding, so when you go for void, there is hesitancy. So hesitancy is first thing. The second is when you go for void, then we have poor stream. So poor stream, not only the stream is poor, it is also intermittent. So start stop, start stop, start stop, and then when you stop it, there is post void dribbling. Even after the cessation of your stimulus for micturition, the drops are falling, and once you complete the micturition, there is a sensation that I have not been able to evacuate the prostate, the bladder properly. So there is known as near retention. So these are the properties which are seen in voiding. बच्चे, LUTS can be seen with bladder outlet obstruction, it can be seen with prostatic etiologies like BPH, prostatic cancer, it can be seen with urethral strictures also. So Paul Adams or Paul Abrahams was the person who coined this term, so everyone should be knowing about. Bachche, next thing is, what are you seeing in the image in front of you? So the next image, the series of images that we have. So sir, it is looking like some wire with the adapter, or someone is saying sir ये तो iWatch का charger लग रहा है, so ये मैं अपनी घड़ी charge कर लूँगा. So something looking like an iWatch charger with a, you can say, a disc like connection. बच्चे, what are we looking at? We are looking at the shunts. And what are these shunts? We are looking at the different type of VP shunts. I hope we know that these are ventriculoperitoneal shunts. So कब use करोगे और क्या important चीज़ें हैं? Let us understand about them. So how you identify them? So they are having two connectors. So this is the one which we keep in the ventricles, and this is tunneled and taken to the, you can say, abdominal cavity. When you talk about the VP shunt, there is something, एक आप ये सोच रहे हो कि सर ये तो चार्जर जैसा लग रहा है, पर ये चार्जर क्या, it has been repaired or something like this? There are a lot of things that we can see here. For an example, if you see, there are two magnets. So this chamber pressure is controlled by the magnets. So these are the shunt chambers. These are the shunt chambers. So what is, you can say, the thing that is done in shunt chamber? Shunt chamber contains the valve, and these are pop-off valve. ये भी पूछा गया है, pop-off valve. Pop-off valve, simple सी बात है, pressure बढ़ेगा, खुल जाएगा. Pressure कम होगा, कम हो जाएगा. So based upon the shunt chamber, so it contains the pop out or pop-up valves, and the threshold pressure of these pop-up valves will decide whether it is a low pressure shunt or high pressure. Simple सी बात है. If it is a low pressure shunt, छोटी छोटी बातों पे the threshold is crossed and the more and more CSF is drained out. There is a risk of collapse of ventricle resulting in cystic hygroma. So low pressure shunt will have a higher, you can say, patient satisfaction in terms of the CSF outflow and controlling the intracranial pressures. But the problem is, since the pressure is low, there is a high risk of collapse of the ventricle resulting in the CSF hygroma. Go to my routine lectures, neurotrauma में मैंने अच्छे से समझाया. Then on the other side, we have the high pressure settings. So when you keep a high pressure setting, the threshold is high, so less you can say incomplete cure from the intracranial hypertension is there. But दूसरी चीज, sir, what is the significance of the shunt chamber? Answer is, we always have a cavity here, a chamber. बच्चे wall बनाना तो single wall बना देते. Why to keep a chamber? The chambers are kept so that we can take out the CSF sample from here. So why the CSF sampling is done? Because the shunt thrombosis, the shunt infection. So whenever we have any problem with the, you can say, with the shunts, we can always take a CSF sample from this and understand whether there is blood, whether there is infection, or this is what is the control, you can say, control chamber. So what are the complications? I have told you. The most common complication is blockage. The another complication is the sepsis that can happen. When is it introduced? It is for the intractable intracranial hypertension. VP shunts are preferred for non-traumatic cases like tumors, for patients of you can see idiopathic intracranial hypertension. Let us move forward and let us understand this image. Bache, this is a very simple image. Already I have taken biliary injury in complete depth. Identify the biliary injury as shown in the image. My favorite topic. पिछले साल भी नीट पीजी में क्वेश्चन INI सेट में क्वेश्चन आया था, हनूवर क्लासिफिकेशन आपके लेवल पे. आई वॉज नॉट एक्सपेक्टिंग दिस हनूवर क्लासिफिकेशन. देयर इज ओनली वन बुक, or rather you can say two books, Blumgart and Shackelford. Even Mengo has not referred. So I was quite surprised. Luckily I have taught it in the last session before that exam also. I have taught that. But not many people, because आधे लोग मुझे पागल समझते हैं कि दादा keeps on teaching very good content, but this is not my level. बच्चे, why you are thinking this way? Because you people are not understanding the subject nowadays. You are going for mugging concept. आप देखते हो आज एक टीचर 10 सब्जेक्ट 15 सब्जेक्ट, someone is teaching all 19 subjects, they are creating mnemonics, they are creating a super hype and they are saying यही आएगा. So you are yourself downgrading your standard. You are mugging up a subject which is hardcore clinical and you are just getting swayed. आपके अंदर एक फोमो आ गया कि यार उनकी क्लास नहीं करी तो मेरा कुछ नहीं होगा, and this way you are ruining your career. Still you have time. मैं कहता हूँ एक साल सिलेक्शन लेट हो पर अच्छे से होना चाहिए. You should go into the medical college with all the swag because someone is going to devote his whole body to you. And imagine the new generation, the Gen Z doctors coming up, mugging up, making the mnemonics, and then you learn the surgery with mnemonics. Oh my God, this is going to be the really hell. So what is this? What are you seeing? Here you are seeing the lateral wall injury, or you can say tangential injury of the bile duct, and this is what is the classical according to Bismuth-Strasberg. So एक है Bismuth-Strasberg classification. बच्चे इसके बिना तो आप एग्जाम में नहीं जा सकते. बच्चे Bismuth-Strasberg is anatomy based. It is the anatomy based classification. The second is we have the Hanover's classification. When you talk about Hanover's classification is the biliary anatomy. So it is anatomy based, but here it includes vascular injury also. So if there is a vascular injury also, bache, it will be included in this. Let us quickly understand. Already in last, you can say, सर्जरी विजुअल ट्रीट, आई हैव डिस्कस बिलियरी इंजरी. यहाँ पर मैं आपसे क्विकली क्लासिफिकेशन के बारे में डिस्कस करूँगा. तो बच्चे, जो पहला क्लासिफिकेशन आपको मैं डिस्कस करने जा रहा हूँ, दैट इज़ अ बिस्मथ-स्ट्रासबर्ग क्लासिफिकेशन, एंड दिस इज़ द मस्ट नो मस्ट गो टॉपिक. बच्चे, बिस्मथ-स्ट्रासबर्ग क्लासिफिकेशन की जब भी कभी बात करोगे, it is into 5 types: A, B, C, D, E. So A is GB stump leak, or you can say cystic stump leak. So cystic stump leak, or you can say or minor duct injury. So minor duct injury और cystic stump leak मतलब है कि ये गॉल ब्लैडर आपने रिमूव किया, दिस इज द सिस्टिक स्टम्प, यू हैव पुट द क्लिप्स और यहाँ से लीक हो रहा है, दैट इज टाइप ए, और मे बी देर इज अ स्मॉल डक्ट ऑफ लश्का. व्हाट इज टाइप बी? इट इज द सेगमेंटल डक्ट इंजरी. बच्चे व्हाट डू यू मीन बाय सेगमेंटल डक्ट इंजरी? वी मीन बाय सेगमेंटल डक्ट राइट हेपेटिक, लेफ्ट हेपेटिक, पोस्टेरोलैटरल, पोस्टेरोएंटीरियर. सो ये सारी राइट पोस्टेरोएंटीरियर, राइट पोस्टेरोलैटरल. सो सेगमेंटल डक्ट इंजरी with blockage, with obstruction. What do you mean by segmental duct injury with blockage or obstruction? Imagine you miscalculated the right hepatic duct, और आपने right hepatic duct को clip करके and you have decently divided the right hepatic duct. So injury तो हुई है पर leak is not there. So since there is no leak, that would be known as type B. Then we have the type C. What is type C? It is defined as segmental duct injury with the bile leak. What do you mean by this? बच्चे डिफरेंस को समझना. सपोज यू हैव डैमेज द राइट हेपेटिक डक्ट, ये आपने राइट हेपेटिक डक्ट को डैमेज कर दिया, बट यू डिडंट क्लिप, यू डैमेज इट, यू वर डूइंग दिस सेक्शन, यू डिड अ थर्मल इंजरी और विद अ सिजर यू डैमेज. सो यहाँ पर डैमेज है एंड बाइल इज लीकिंग आउट, सो दैट इज सी. अगर क्लिप कर दिया ऑब्स्ट्रक्शन है तो इज बी. If it is with the, you can say, bile leak, that is type C. Then what is type D? That is a lateral wall biliary injury. So lateral wall biliary injury, this is what is, or you can say bile duct injury, main bile duct injury. This is what is type D. So suppose this is the right hepatic duct, this is the left hepatic duct, and imagine there is a rent in the main biliary tree. इसको बोलते हैं type D. And then type E is for the stricture. बच्चे again bismuth Strasbourg should be on your fingertips. अब stricture की बात करोगे, so lot of things depend upon where the stricture is. So remember, this is the hilum. If the stricture is located more than 2 centimeter away from the hilum, then that is E1. If it is less than 2 centimeter away from the hilum, then that is known as E2. If it is at the hilum, then that is known as E3. If it is at the right or left duct with hilar sparing, so hilum is spared but the duct is right or left segmental duct, so hilum spared, this is what is known as the type E4. So just try to understand, suppose you have a stricture like this, so this is a E4 stricture, and if it is right or left with hilum involved, so if it is the hilum is also involved, then this is, suppose this is the type of the stricture, so hilum is also involved here, this is what is known as E5. So E4, E5, this is really very important. बच्चे हेनूवर क्लासिफिकेशन मैं बस आपको क्विकली बताऊंगा, समझाऊंगा, आप याद रखते हो इट्स गुड, आप नहीं याद रखते हो कोई दिक्कत नहीं है. When we talk about Hanover, this is at least आप नाम ही याद रख लो अपने लेवल पे, that is good. So Hanover classification for biliary injury type A is GB fossa leak. That is the same thing. So what is GB fossa leak? Suppose cystic stump leak है, minor duct injury है. Type B is biliary injury with obstruction. If you go to my routine lectures, वहाँ पर मैंने डिटेल में पढ़ाई है. What is B1, what is B2, what is A1? A1 means a cystic stump leak. A2 is the GB fossa leak. Basically, I would call it a peripheral bile leak. अगर आप ओरिजिनल क्लासिफिकेशन देखोगे तो उसमें वर्ड यूज होता है पेरिफेरल बाइल लीक इज A. उसमें A1 होता है सिस्टिक स्टम्प, A2 होता है GB फोसा. आपको हेनूवर तो याद नहीं, आप नाम का आप क्या करोगे, डिटेल में मत जाओ. B1 इज पार्शियल ऑब्स्ट्रक्शन. बच्चे क्या होता है ऑब्स्ट्रक्शन समझो. अगर सपोज आपने सिस्टिक डक्ट पे की बजाय मेन बाइल डक्ट पे क्लिप लगा दी, सो दिस इज ऑब्स्ट्रक्शन, दिस इज ऑल्सो ऑब्स्ट्रक्शन, दिस इज अ कंप्लीट ऑब्स्ट्रक्शन, this is complete obstruction and therefore it will be known as B2, and this is incomplete obstruction, this is known as B1. छोड़ो इसको. Then C is tangential injury. So when we talk about tangential injury, the injury pattern that you have seen there. So imagine there is injury like this. So this is what is known as a type C. Again, C is divided into 4 types. What is 4 types? C1 is defined as less than 5 mm tangential injury. C2 is defined as more than 5 mm injury below the hilum. So if it is below the level of hilum, this will be known as C1 and C2. But all these, the PDF will be attached to the class, don't worry. But what is C3? Injury at hilum, and what is C4? Injury above hilum. Now whenever you are injuring the biliary structure, there could be possibility कि आप ना कोई vascular structure भी damage करके आओगे. So along with this C, now this is where the trick comes. So it is D for right hepatic artery. So imagine you have damaged the right hepatic artery and also you have a 1 centimeter rent below the hilum. So it will be known as C2D. Why? Because D क्यों? क्योंकि आपने right hepatic artery भी करी है. Then we have L. When we talk about S. So D, then S is for left hepatic artery. Then we have P. What is P, students? This is for hepatic artery propria. So if it is hepatic artery propria, that is main hepatic artery को injure किया there. Then we have a COM. What is COM? It is damage to common hepatic artery. Then we have the cystic artery. So if you are damaging the cystic artery, then we have PV. PV stands for portal vein. बच्चे जिसको डैमेज करोगे वो आती है. This is what is really very important. So if you have damaged it at the level of hilum, so क्या आ जाएगा hilum? It will be C3. And along with that, if you have damaged portal vein, so C3 PV. तो इस तरीके से Hanover को लिखा जाता है. Then we have seen A, B, C. Then what is D? D stands for complete transaction. So complete transaction, this is suppose you have injured, that is C. Suppose आपने पूरा का पूरा ही divide कर दिया. So you have divided it completely. ये आएगी D में. So this is not a tangential injury. This is a complete transaction. Again we have D1, D2, D3, D4. What is D1? Complete transaction without gap below the hilum. D2 is complete transaction with gap below the hilum. D3 is any transaction at the level of hilum, and D4 is any transaction above. Apart from this, इसके साथ भी same. You have to add D, you have to add S, you have to P, you have to have COM, you have to C, portal vein, and then E stands for stricture. This is how you define the biliary injuries. Do check out my last video where I've discussed the biliary injury management in detail. Anyways, in the next sessions also we have a lot of questions on biliary injuries and we would be revising it. So I hope you are enjoying this IBQ based surgery visual fest, and we will be continuing it for next 5 days. We will be doing literally all the surgery images. So do recommend it to your friends. If you are still not joined us, ask your friends to join us and enjoy this. Give a last push to your preparation. Remember, Dada will not leave any stone unturned for you. I will do my level best to make you confident at least in surgery. मैं निमोनिक फिमोनिक नहीं, मैं गाने वाने या नाच गाना नहीं दिखा सकता, बट मैं वो दिखा सकता हूँ जो एक सर्जन दिखा सकता है, and that is what is the genuine core concept of the subject. So till then, bye bye.